Our final speaker for this morning is going to be Ed Keystone again, and Ed's going to predicting long-term outcomes in rheumatoid arthritis.
Thanks very much. It's great to be back. I just want to, let's move on here. So I wanted to show you this slide again because I just want you to know that nothing has changed since I went into the exhibit hall and came out. So I just wanted to make that very clear. Okay, so the disclosures are done. Okay, so we've done very well. We're really improving patients a great deal, putting them into remission, low disease state, particularly later in disease, but we could do better. And these are some of the questions, obviously, that we need to know. Who's going to respond? Who's not going to respond? Who should we treat aggressively? Who should we not treat aggressively? What's the timing in terms of response? Should we, as we heard today, should we quit at 3 months? Should we go to 6 months? And what is the algorithm of the use of these biologics? The last question, of course, is up in the air still, but of course there are some, I would say, possible guidelines in terms of how you're thinking about this. So those are the questions, and then the question is, how are we going to address them? And I've done it in a number of ways. Number one, we're going to just talk briefly for a few minutes about the, quote, usual clinical outcomes that determine progression, whether it's radiographic or clinical. We're going to talk about a relatively new concept, probably been around a long time, but an important one, and that is the timing of the response that actually predicts how you're going to do. Not just the outcome itself, but the timing. And then we're going to talk about sustained remission. What are the predictors that your remission will sustain or not sustain? And then finally, I'm going to talk a little bit about biomarkers. I was going to talk, I had some genetic stuff. I took it out because Gerd Burmester I thought would be here, but he couldn't make it. I was going to have him chat about the genetics part. So let's just go through what we normally do, that is the classic predictors. And everybody knows or should know what the classic predictors are of a poor prognosis or radiographic progression. Very straightforward. If you're female, you're not going to do as well. If you're a smoker, you're not going to do well. If you have high disease activity, whether it's tender joint, swollen joint, DAS score, HAQ score, the HAQ and DAS, all of those will determine basically you're not going to do so well. And then, of course, there's the serology. Rheumatoid factor, anti-CCP, you're not going to do so well. And then what I love most is one of those in there says, and if you failed lots of drugs, you're not going to do well. My mother could have predicted that one. And my mother is okay, but you know, she's not brilliant. So the point is that there's some obvious things. So I'm going to just show you for a moment the smoking concept here. And there are 3 bars here. One of them is, for example, this is the percent of people who respond. And if you're a non-smoker, for example, never, you respond well. The middle bar is that you had been a past smoker. And the right-hand bar for each one of those, the dark bar, means that you are a present smoker. And notice the response to therapy, not just the long-term outcome, but the response to therapy actually is predicted in some ways, in general, by whether you're a current smoker or not. And it doesn't matter whether you're on methotrexate, whether you're not even on a DMARD, or no DMARD at all, or even on a TNF. It does not matter. Smoking is a problem in terms of determining response to therapy. I think we need to know that. And then we talked for a few minutes about CRP, about SED rate. And it's interesting in terms of predicting progression over time. And this little table says it all. It says you've got a 4 times possibility of progressing rapidly or progressing if your SED rate and CRP are both elevated. If only one of them is elevated, you're less so. And if none of them are elevated, you have even less chance of progressing. Now remember, that is, in general, it's a probability, it's an aggregate data, but it doesn't say the individual. And everything I talk about today is going to be in general, that is, we're looking at aggregate data, overall data, but not in the individual. It's very tough, no matter what I tell you here, to actually predict in an individual. And I think that's really important. It's all about probability, but you can't say in the individual what's going to happen. So the other point is, in terms of CRP, which is interesting, this goes back a long way. They said, oh, you know, if you've got a high CRP, then using, let's say, infliximab is going to have a better result relative to the placebo. So, in fact, take those patients who are the sickest with a high CRP, and chances are you'll do better than if your CRP is normal. But if you look carefully at that graph, what you see is the placebo keeps getting worse with higher CRP, but the TNF inhibitor, infliximab, doesn't change all that much. So, of course, there's a bigger difference between the placebo, methotrexate alone, versus the TNF inhibitor if you have a high CRP. It's not that the CRP so much reflects what's happening to the TNF inhibitor, it's what happens to the placebo, so that delta or that difference increases. Okay, now, here's an important question. Everybody uses baseline characteristics. I just showed you all that data was all baseline, you know, your DAS, your HAC, your CRP, that's all baseline characteristics. The question is, and it's really an important question, what if we look at your outcome at 3 months after the onset of therapy? Let's say whether it's methotrexate or TNF, can we learn more about predicting how you're going to do from 3 months data than we can from baseline data? And the answer is actually yes. And this is, let's see, here we are. This is the data here that says at 3 months, you have a much better correlation to what's going to happen clinically and what's going to happen radiographically. The radiographic stuff I didn't show you. This is the clinical stuff. And what does it say? It says that if you're at baseline, you'll look at the correlation coefficients, which are, I'll show you right here. There's very little correlation between initial baseline pain score, global, swollen joint, tender joint, physician global, but there is a large difference in terms of the correlation coefficient at 3 months. They're 0.5. 0.5 means that's a pretty good correlation. It's not fabulous, but it's a reasonable correlation. So the message is everything up there, except 2 things, which is interesting, the HAC score and the tender joint count do not correlate very well, even at 3 months, but all those other outcomes correlate at 3 months better than if you looked at your baseline characteristics. So the message is, you know, what happens at 3 months may be important. So, an important concept. There are 2 ways that you're going to look at outcomes. One, you're going to either look at the response, how did I respond? Or 2, you're going to look at the disease state that you achieved. Now, for my money, and Canadian dollars are now worth more than yours, I just want you to know, I know we had dollarettes for a long time, but you have American dollarettes now. So, you know, so be it. We feel better. So the point is that the disease state for me, moi, at the end of the day is really what counts. Yes, I want to know response. Yes, it's important, and you'll see, we'll talk about responses, but where you end up is really where you should be making your decisions at the end of the day. Not how well you responded, although you can take that into consideration, but actually where your final disease state is, because your final disease state is indeed going to predict how you're going to do over time if it persists. Okay, so now the issue here is, and it's an important issue, if I just look at disease state at 3 months, that is how I am at 3 months, can that predict, and how good is a disease state at 3 months predicting how I'm going to do? So this is a study, an important study by Alataha and Smolin that says, you know, I'm going to measure the SDI, disease activity state, in a sense. It's not the DAS, but it's the SDI, Simple Disease Activity Index. I'm going to measure it at 3 months. And I'm going to measure it in late disease. I'm going to measure it in early. Early disease is on the right, late disease is on the left. And along the bottom is the degree of disease activity based on the SDI at 3 months. And then I'm going to ask the question, what are the chances of getting into low disease state or remission if I have a high SDI at 3 months? And the answer is, in fact, if my SDI is high, my probability of remission or low disease state is about 0. And if my SDI is low, here in early disease or there in late disease, you can see I have a high probability of doing well in 1 year. That is, achieving a low disease state or remission. So the message, according to Joseph, initially was that, in fact, what you were like at 3 months was going to highly correlate with what you're going to be like in a year. Now, the question then is 3 months enough? In other words, is 3 months it? If I'm not where I want to be in 3 months, do I have to move on? And that question was addressed earlier, or at least it was asked earlier, whether 3 months is enough or should we go longer.